Welcome to the second part of week 5, which is to do with decision analytic modeling. And in the last part, we discussed how to do decision analysis in general. And now we're going to try and see how it applies to economic evaluation. And before we do that, we are going to expand our knowledge, not just of decision modeling, but of modeling in economic evaluation in general. And decision analysis, like we said, can be applied to many fields, but now we're going to narrow down on not just the use of the decision analytic model itself, but of the broad theme of modeling as it applies to performing economic evaluation studies. So there are two approaches to economic evaluation, and one is to use models, which is what we are talking about here, but the other one is to use trials. So you can do economic evaluations alongside clinical trials, and these are called trial-based economic evaluation. So you get the evidence for intervention costs and effects from the trial. So if you have a trial for two medicines, comparing a new medicine to the standard of care or placebo, then you can use those data to do your trial-based economic evaluation. And models are essentially the second way of doing economic evaluations, and these are called model-based economic evaluations. And the model is used to synthesize all available evidence, including, if needed, multiple randomized control trials. So when you use a model, you can take data from trials, from longitudinal studies, even from experts. So you can get data from multiple sources, and take all this data and build a model and put them into your model and be able to do your analysis. Randomized control trials are limited as the basis of pharmacoeconomic assessment because of some clear limitations, and we're using the word pharmacoeconomic, but we can always say applied health economic. But the reasons are that in trials you are assessing efficacy and not effectiveness, and effectiveness is essentially real world. And if you have a policy application, you usually want the real world effectiveness. And this also gets at the issue of internal validity, which means the validity within the experiment. So it's to do with minimizing bias and confounding. But external validity is also called generalizability. And this is what you're looking for: how an intervention affects outcomes in real populations. The time frame for trials is usually short, and the medical use is usually protocol driven, and it's not quote unquote organic. It's not as it would be in real life. Trial sample sizes are usually smaller, and you're usually comparing to a placebo and not to a realistic option. And usually we want to compare to standard of care if we have policy applications or even clinical applications. And then the last point is that selection of participants is the participants are carefully selected. They are carefully selected. And these participants are selected to maximize the potential for the trial to show benefit of the intervention. So for all these reasons, trials are limited as vehicles of performing economic evaluations. So what are some of the uses of economic evaluation models? And let's give some examples. You can use them to extrapolate beyond the time frame of a clinical trial. So let's say you had a trial that ended at 12 months and measured some outcomes, and you wanted to do a study with a lifetime horizon. So what you could do is use a model to bridge the gap between the 12 months and the lifetime horizon. The other one is to link intermediate outcomes like hyperlipidemia to final outcomes like life expectancy. So maybe a trial measures hyperlipidemia, but you want to measure the impact of the intervention on life expectancy. So you can use a model to bridge that gap again. Trials can also be used to generalize to other settings. Maybe the trial was performed in one country, and you can build a model that tries to see the impact, the potential impact of the intervention in another country. You can use models to synthesize head-to-head comparisons. And finally, you can build models and use them to inform decisions in the absence of hard data. So those are some of the uses of economic evaluation models. But there are some concerns about modeling. The first one is that you can use the data, clinical data, inappropriately. The second one is that there may be some biases that come in from observational data. So if you use observational data to inform a model, it might be that you carry over the biases. Sometimes there are difficulties in extrapolation, and then there's an issue of transparency, and sometimes modelers are accused of not being transparent, of building models that people can't follow, and sometimes models lack validity. There's an issue that modeling is unregulated. It's unregulated. There's no central processing store for models that they can be controlled and that they can be standardized. So it's related to the issue of standardization. And many people say that there's plenty of room for gaming models, and you can tweak the answers to fit your purpose. So let's recap. Essentially, decision modeling is mathematical relationships that we learned in the first part, in decision analysis, and you can use these to define a series of possible consequences that come from different options being evaluated. And model inputs determine the likelihood for each consequence, and each consequence can be assigned a cost and an outcome, and using this you can calculate the incremental cost effectiveness ratio or decremental cost effectiveness ratio. And for a given option, the expected cost or outcome is the sum of the costs or outcomes of each consequence is weighted by the probability of that consequence, which is exactly what we did in the last part with the example on Ebola. So the key purpose of decision modeling is to allow for variability and uncertainty associated with decisions. And the structure of the model reflects this variability. So if you have a treatment and you have responders and non-responders, and you can represent them in a dichotomous branch in the tree. So you have responders and non-responders. And essentially what that does is that given that you are unsure whether a patient will be a responder or not, you can assign a probability, and this parameter will allow you to capture this uncertainty. So the probability is the likelihood of response or non-response. And you can vary this probability in sensitivity analysis to capture this uncertainty. So for economic evaluations, the decision in decision analysis has to do with resource allocation decisions. So an example of a question to be answered would be, should a country provide free second-line ARVs, or should a clinic use malaria RDTs to treat malaria presumptively? To make economic evaluations relevant to decision makers, you need to synthesize all available evidence. And an advantage of modeling is that it provides a framework in which you can do that. Modeling allows you to get evidence from multiple places, and we touched on that in a previous slide. The other thing is that modeling allows you to consider all relevant or feasible comparators. And a single study, like a randomized controlled trial, may not include all the relevant options. But if you build a model, you can then include all the possible or feasible comparators. So the other advantage of models is that they can be used to expand the time horizon. We know that the appropriate time horizon needs to reflect all key costs and consequences and the differences between the options. And if you have data from a trial, it might not capture the appropriate time horizon. So modeling can allow you to expand that time horizon to extend baseline costs and effects beyond the primary data source. And finally, modeling allows you to capture uncertainty. It allows you to indicate how uncertainty in the evidence leads to decision uncertainty. So if you change a parameter, let's say the baseline parameter is the probability is 0.2 and the range is 0.3 to 0.1, the decision uncertainty reflects the fact that if decision A is made with a baseline parameter of 0.2, what would happen to that decision if the parameter changed to 0.1 or 0.3? So models allow you to do that kind of analysis where you can examine the impact of uncertainty in the evidence on uncertainty in the final decision. So here is the typical situation in which modeling would be used. You have a treatment comparison. You have A, which is a new intervention, and you're comparing it to the standard of care. And once you do the epidemiology, maybe it's in a trial, you measure efficacy, clinical outcomes, something like safety. And then you are interested in your evaluation in ultimate outcomes. And these ultimate outcomes include the use of resources, the quality of life, and the survival. And there's other dimensions like the value of reduced uncertainty, but this is what you're ultimately interested in. And essentially, models allow you to make these kinds of projections. So let's say that the aim was weight loss, and weight loss improves surrogate comorbidities. So it improves glucose tolerance, it reduces cholesterol, and it has an impact of reducing an individual's blood pressure. And this would lead to improved clinical outcomes. It would lead to less strokes and less heart attacks. But we aren't interested in strokes and heart attacks per se. We are interested in life expectancy and quality of life. So if you have a study that measures only those, or even measures only those, you can model the impact of improvements in these on the ultimate outcomes. So you can go to the ultimate outcomes of life expectancy and quality of life using a modeling framework. Now that we've introduced the use of decision analysis in economic evaluation, let's use the example of Ebola that we set out in the last part and add some costs. Now, the outcomes side, assuming that we are doing a cost per life year saved, or a cost per life saved, would be the same, because we had the example that compared the use of the drug XMAP to no treatment, and the objective was to maximize survival. So we have our old data. We had the risk of an adverse event at 0.15 and the risk of death from an adverse event at 55%, and the cure rate with no adverse events at 85%, and then baseline mortality without treatment at 35%. So we had this data in the previous part. So let's add some cost data. Let's say that XMAP is an expensive medicine. It costs $10,000. And this is not uncommon, not the amount, but the fact that new treatments are usually more expensive because they add value and there's a premium on innovation. So companies want to recoup their investment. And let's say that managing the side effects of XMAP costs $1,500, and that standard supportive management costs $250. So, using IV fluids and using nurse time and physician time costs $250. And these are per patient costs. And for the supportive management, we are saying all patients, including those who get XMAP, get supportive management. We're doing the calculation now and adding the cost side, and you'll see that the products of the branch probabilities, these estimates, are unchanged from our previous calculations. However, we are adding, instead of having a payoff for survival, we are having a payoff for cost. So we have this $10,000 here, and it reflects the cost of XMAP right here. So for every branch that has XMAP, we have $10,000. For every branch that has an adverse event, we have an adverse event cost, and that's those two branches. And for every branch in the model, we have $250 for the costs of supportive treatment, which includes things like IV fluids and antipyretics. So once again, we multiply the product of the branch probabilities by the sum of the payoffs. So for XMAP, the mean expected cost of XMAP is these estimates times the sum of these estimates. So this is 0.0675 times 11,750, which comes from these three, and plus this one, plus the same amount, which comes from these three, and so on and so forth. And the expected value of the XMAP is $10,475 on average. And for supportive treatment, it's $250. So that's how you calculate the cost side. So the solution is that treating with XMAP results in a higher expected cost. So the question now becomes, is XMAP cost effective? And we ask ourselves, which quadrant of the cost effectiveness plane is XMAP? And you know that this plane is the plane of cost, and this is higher cost and lower cost, and there's higher effectiveness here and lower effectiveness. If there's higher effectiveness and lower cost, this is a dominant strategy. You definitely do it. If it increases cost and lowers effectiveness, it's a bad strategy. You don't do it. In this quadrant, if you lower costs and you have lower effectiveness here, then you calculate a DSA. And if you have higher costs and higher effectiveness, then you calculate an ISA. And since XMAP increases cost and increases survival, it is in this quadrant, and we need to calculate an ISA. So here is the ISA calculation. We know that on average, supportive management was $250 and treatment with XMAP was $10,475, and the incremental cost, which is the difference, is $10,225. We know that survival under supportive management was 0.65, and it increased to 0.79 with XMAP, a jump of 14% or 0.14. And if you do, the change in cost over the change in effectiveness, you get this ISA of $73,000 per life saved. So let's extend our thinking a little bit and continue to ask ourselves how we would decide whether this $73,000 per life saved is cost effective. Now you remember we had three ways of deciding if an intervention is cost effective, and these three were by threshold, by benchmarking, and by league table. And if you have forgotten these, it wouldn't be a bad idea to review them. But the point I wanted to make is that this $73,000 is per life saved, and it's not per quali gained or per DALI averted. Now, if you wanted to convert this amount into per life year saved to get at even one aspect of the quali or DALI, you would need to multiply the survival, which we estimated here, this survival, you'd need to multiply it by the life expectancy. So to be able to decide whether it's cost effective using these three methods, you need to take it to cost per quali gained, so you can compare with other healthcare interventions in a league table, or to benchmark on some intervention that has been paid for in the society, or to use a threshold, which is usually based on GDP per capita. But the point I really wanted to make was the fact that this ISA is in costs per life saved, and it actually does look cost effective in most jurisdictions. So we have our example. In the previous part, we had this spreadsheet. in which we calculated the survival and we did not have cost estimates, but now we have added cost estimates to the spreadsheet. The mathematics doesn't change up to the branch product, and we have our payoffs still included in survival, but we have new payoffs, and these new payoffs are a reflection of the different costs. And if you look at the cursor, you'll see where they're coming from. So for this branch, this top branch, it's the cost of XMAP, management of adverse events, and supportive management here. And if you now go to the next one, it's the same thing. And if you go to the next one, it's now only the cost of XMAP and supportive management. And so once you have this set up, once you have this model set up, you can then go and calculate the costs. So here's the cost of supportive treatment, and there is the cost of XMAP. You can follow the calculations in the spreadsheet. The incremental cost is the cost of XMAP minus the cost of supportive treatment on average, and you can see where it comes from. And then you have the survival, which we calculated before. That's where the estimates come from. They still use the product. And then you have the incremental survival, which is the impact of XMAP on survival. And then you have the ISA. And as you can see, it's the same ISA we got using the hand calculation. So you can effect a cost effectiveness analysis or an economic evaluation using Microsoft Excel. So with this, we come to the end of the second part of week 5, which was looking at application of decision analysis in economic evaluations. And in the next part, in the third part, we're going to look at sensitivity analysis. Thank you very much. I'll see you in the next video.